away.
Great. Well, good afternoon, everybody, and welcome to the SADS Foundation Live. Amazing times we're in. My name is Mike Ackerman, and I've had the privilege of serving as president of the board for the Sudden Arrhythmia Death Syndromes Foundation and serving alongside Alice Laura, our chief executive officer. And so we're delighted to do this. I'm delighted to join you. Never done Facebook Live before. I'm not even sure I know what Facebook is, but we will do our best in this time of need to make you feel connected and see what questions are on your mind. And if you like what we're doing and you like this, and if it brings benefit, we'll probably do this same time, same channel next week. And I'm Michaela, who is going to sort of moderate this, is going to give us your questions. And Michaela, should we just take it away? I'm here in self-quarantine, called my office, all alone, and practicing physical distancing and starting to do telemedicine appointments with my amazing patients. So I'm here at Mayo Clinic in Rochester, Minnesota. And if you didn't know, I'm a genetic cardiologist devoted to families with genetic heart diseases like long QT syndrome and the other heart conditions that we at the SADS Foundation love to support. So I'm looking forward to your questions. So Michaela, let's get started.
Great. I'm excited. Okay, so our first question is from Ann Taylor Karras. She says, I have 2 young boys, ages 8 and 3, and a husband on Nadolol, so beta blockers. I was wondering if the beta blockers are having the same effect of coronavirus patients as the ACE2 inhibitors. Do we need to worry about their medicine making them worse? My 3-year-old has some beta blocker response in his lungs and has some sounds when he gets sick.
Yeah, and great question. I know you saw, obviously, with your question, some information about the ACE2 blockers or the angiotensin receptor blockers and so forth. I think bottom line, long QT patients are at no greater risk of coronavirus, of either getting it or having a more severe case of it than any other otherwise healthy young person. So no need to fear about that. The risk category is exactly the same. The long QT status, no matter what your genetic state is, doesn't change that. Your Nadolol beta blocker therapy is absolutely the right beta blocker to be on and to stay on. And so of all the things that we probably can and may concern ourselves with and be anxious about, I would set the anxiety meter on this particular issue at 0. So don't be anxious at all. Stay on your beta blocker and proceed with all of the other strategies that all of us are doing of physical distancing, washing our hands, and so forth. So great question, Ann. Thanks for getting us started with that one. I can't actually hear you, Michaela, now. You disappeared volume-wise.
Oh, I muted myself on accident. There we go.
There you go.
Okay, so the next question is from, where'd that one go? Marsha Anderson. So it's in relation to CPVT. They have a diagnosis. So it says, my daughter had a cardiac arrest when she was 15 years old. She now has an ICD and uses Nadolol for beta blockers. Do you know if she is in the risk zone of the COVID-19 virus, so specifically for CPVT?
Yeah, great question, Marcia. So CPVT is one of our other genetic heart rhythm conditions that we support families with. It stands for catecholaminergic polymorphic ventricular tachycardia. And like long QT syndrome, there is no evidence of increased risk. And I think that these questions are really important because there was a pronouncement that came out last week that honestly wasn't helpful at all, because it sort of casted a broad brush, and many of you families saw it, which was the statement of patients with quote unquote heart disease are at much greater risk of coronavirus complications and are less likely to be part of the 80% of all of us where if we get it, we're going to be asymptomatic or just trivially symptomatic. But it left the impression, yes, but if I have heart disease, I'm more likely to join that symptomatic group and that potentially dangerously symptomatic group. I quickly tweeted out a correction to that and saying, this is not a one-size-fits-all designation of heart disease. And by heart disease, that was really referring to the risk category that we already know about, that if we are elderly, 65 and older, and if we are elderly with heart diseases like heart failure or heart failure with reduced ejection fraction, or coronary artery disease where we have stents in our coronary arteries, and those more adult type heart diseases that are acquired, that's the subset at greatest risk of coronavirus complications, along with immunocompromised individuals. But for our patients who are young, with genetic heart disease of the long QT syndrome variety or the CPVT variety or Brugada syndrome, there's no evidence that I have seen or heard of increased risk. Probably the single most important thing we would need to counter if we have any of those genetic heart conditions, and if we were to have a febrile illness of any kind, coronavirus or any, is to take measures to reduce the fever. But in and of itself, again, CPVT, you're on a perfect drug for it, and stay on that medication, and don't worry about being at increased risk. There's no evidence for that. You're not. If you were to get a fever of any sort, take steps to lower the fever. And in the case of coronavirus, I think until we learn more, the anti-fever medication that's probably the safest is acetaminophen, Tylenol, rather than using ibuprofen or Advil. So great question, Marcia. Thank you.
Great. Okay, so we have gotten a good amount of questions asking about certain medications that are being used for the coronavirus, specifically hydroxychloroquine, I think is how you pronounce that. So there's been people asking about the safety and the risk versus benefit of that, of taking it if you have a SADS condition, since it is known to be on the list of avoiding those drugs. Right.
This is a great question. And this is sort of hot off the press over the last few days. So as all of us with long QT syndrome know, there's a hit list of drugs that are potentially QT dangerous or QT prolonging. And there's a perfect website that we link to at the SADS Foundation that's maintained by a very good friend and colleague of mine, Dr. Ray Woosley, called crediblemeds.org, that constantly is reviewing and looking at the veracity and strength of the evidence as to how the significance of at that drug being QT prolonging and the consequences of QT prolongation, or the potential consequences, that of torsades or a potentially dangerous ventricular arrhythmia. So that website's a great website. All long QT families should have it on their app and refer to it. And when possible, we try to avoid patients who have long QT syndrome from being on those medications. But there are many, many times, I have many long QT patients, for example, who have long QT and concomitant ADHD, who are on those medicines like stimulants, Ritalin, Adderall, Concerta, Strattera, etc. They're on the hit list, but we've chosen and decided together that the risk-benefit favors the meaningful, intentional treatment of that condition. You see what I mean, Michaela? So this new one is a unique situation right now where we have hydroxychloroquine, also known as chloroquine, trade name Plaquenil, where this will be an incredible story if it turns out to be true, right? Where who would have thought that a medication that has been around for 80 years that's used to treat malaria, it's an anti-malarial drug. Our rheumatologist colleagues also use it to treat rheumatoid arthritis and other arthritic conditions, where that drug is an FDA approved drug for the indications of malaria and arthritis. There are very exciting early in vitro studies and an early clinical study out of France that suggests therapeutic efficacy with using that anti-malaria drug, hydroxychloroquine, for patients with coronavirus infection, coronavirus pneumonia, and so forth. The drug, like you said, is on the QT hit list. And we are right now, as we speak, submitting what I view as urgent guidance for physicians out there who are using this medication, FDA approved, but currently off-label indication, which we can do as physicians for the treatment of coronavirus. There's two camps out there. There's one camp who says, if this works, who cares about the QT risk? Just treat everybody, and if a few people die suddenly from hydroxychloroquine-induced sudden cardiac death, so be it. I don't like that camp. There's the other camp who says, if it works, let's use it, but let's become QT aware of the QT vulnerable host and make sure we mitigate that potential risk with our countermeasures, whether it is having them on telemetry, whether it is making sure their potassium, magnesium is normal. So the bottom line is, if it works, and if a long QT patient, any patient for that matter, got coronavirus and their doctor thought that they would benefit from hydroxychloroquine, I don't think that the diagnosis of genetic long QT syndrome has to mean, sorry, you can't have this medication. It has a QT signal to it. I think what it does mean is, let's figure out how we can do it safely, how we can monitor it. And there are some incredibly exciting ways to monitor it for the QT reaction in a very simple, minimally invasive way. And in fact, maybe I'll wait for the other questions, but I'm just receiving an email that about some FDA clearance for emergency use of a non-invasive QT meter that has been developed. But let's wait for that. Maybe there's more questions about that. That, I suppose, is a teaser. But I imagine if there's other questions about use of chloroquine or hydroxychloroquine and the QT issue and long QT, we'll come back to it. And let's do that. That's an important question. Things are moving really fast on this, and we're working behind the scenes at Mayo Clinic and a company, AliveCor, to come up with how can we monitor for this unwanted QT side effect reaction to make sure we can get this drug, if it works, to everybody and everybody safely without any collateral damage of drug-induced sudden cardiac arrest.
Great, absolutely. Okay, next one, there's not a name with this one. It is asking, is there any research done yet about COVID or coronavirus and long QT syndrome?
Yeah, so right now there's no data that long QT as a disease is a bad combination with coronavirus. Now, long QT, and I'm 80 years old, and I also have emphysema, that's different. That's because of those diseases. There's also no evidence that coronavirus infection itself lengthens the QT interval further. And what we were just talking about is the possibility that a currently available medication, hydroxychloroquine, could be and is being used right now as an off-label use in patients in Washington State, in New York City, are being prescribed it for the treatment of their coronavirus infection. And that medication has QT prolonging potential to it. So we are working to find what's the best, easiest, minimally invasive way to identify the QT reactors, to identify the QT vulnerable, so that we can adjust the therapy, we can do counterattack to it, so we can keep it available for virtually every patient who the doctor thinks may benefit from this treatment right now.
Great. Okay. The next one is asking, would a positive test warrant a hospital stay for monitoring? We are aware of an exposure for my 5-year-old, so we are interested in your comments or recommendations on the best course of action if she becomes symptomatic of coronavirus.
Great question. And I'll preface it by saying, like many of you, I'm learning about coronavirus in real time. I'm a genetic cardiologist. I'm not an infectious disease specialist. So like you, I'm learning about the importance of flattening the curve and social distancing and physical distancing and all these things that who would have thought we would have been talking about this 4 weeks ago, 5 weeks ago. But here we are. And I think importantly, whether you have long QT syndrome or not, if you are COVID positive but doing okay, stay home, stay isolated, stay quarantined. And it's real. My own daughter, 16 years old, one of her good friends is our first immediately, we know that person who is COVID positive, doing just fine, recovering at home. And do not go to the hospital, do not go to the emergency department if you are getting along with your COVID infection. If you are not getting along and you're having increasing shortness of breath with your known COVID positive status, then of course we need to get the mask on and call the hotlines in your communities and figure out what's the best way to get you in isolation and so forth. But the vast majority, remember, the vast majority of all of us in the United States who get COVID infected, 80% plus of us may not even know it. And if we do know it, our symptoms are going to be trivial. Low-grade fever, a little cough that kind of mimics exactly a lot of the cold cough crud that's going around. And then we recover from it uneventfully. So for most of us, it's much to do about nothing unless we didn't know that we had it and then we circled around the nursing homes and the fragile and the elderly and we exposed those as otherwise asymptomatic shedders and then cause catastrophe among our loved ones who are the more fragile and the elderly. So the 5-year-old who's COVID positive, your son, daughter should recover just fine. Keep eyes on, and she or he should recover just fine, like the 80% plus of us will with minimal symptoms.
Great question.
Yeah, great question.
The next one is specifically about CPVT, but it may apply to other conditions. It is asking, do we need to be concerned about the potential for more malignant arrhythmias if we contract COVID-19 or develop a significant fever?
Yeah, I don't know. We don't, honestly, great question. Honestly, we don't know what would be the COVID consequence if we have long QT, in the sense of we're not hearing of a bunch of long QT CPVT Brugada patients who are now concomitantly infected with coronavirus. So when I say there's no evidence, that's no evidence that I'm aware of a signal. Could you raise a good question of could the febrile state that the coronavirus infection could bring about, could that make the CPVT or the long QT or the Brugada more twitchy, more agitable, or more likely to go into the long QT CPVT Brugada triggered danger rhythm? And I think that's true of any febrile illness. So any febrile illness, it makes good sense to take our anti-fever countermeasures and lower the fever pronto, not out of fear, but out of Boy Scout, be prepared. I was a Boy Scout, didn't make it to Eagle Scout. I should have. One of my regrets, I was that, middle school student who was too cool to continue for the Eagle rank. But Boy Scout, be prepared. Girl Scout, be prepared. Not anxious, but prepared, and lower the fever with Tylenol.
Great. Like that. Okay. The next question is asking, should a patient with long QT type 3 contact their electrophysiologist as soon as they are diagnosed?
The great question. I don't think it matters which long QT you have, whether you're LQT 1, 2, 3, 17, calmodulin mediated long QT, CPVT or Brugada. I think if you are known to be COVID positive, any of my patients, I would want any of my patients who are seen here in Mayo's Winland Smith Rice Genetic Heart Rhythm Clinic to reach out to us through the portal. Let us know if they're having any questions or concerns so that we can stay connected. This social distance and physical distancing that we need to do doesn't mean disconnected. And we're here for you, and I'm sure your physicians and their teams are here for you. We, like others, we're rapidly shifting to video medicine for these next 8 to 12 weeks. So patients who were supposed to be coming or wanted to come or now want to come, that we can meet your needs. And that's what we at the SADS Foundation are here for. You can reach out to us at the SADS Foundation, www.sads.org, or more importantly, stopsads.org. We're keeping as everything that we know. We are updating our COVID-19 insights as it relates to our SADS conditions. So connect to us, inform your physician and healthcare provider team. If you are my patient already, please reach out to us, and we'll make sure you know that you're connected and that we can give reaction in real time. But there is no greater risk that we have a signal of in patients with long QT syndrome if you were to become infected, just like my daughter's friend at age 19, 20 became COVID-19 positive. So be prepared, yes. Vigilant, yes. Paranoid, no, please don't. And I put out a hashtag refuse to fear, and I believe that. I refuse to fear. And I would love it if you chose to opt for the refuse to fear pathway. It is a much more peaceful pathway than the fear that is gripping us. So let's be part of the chain that not only breaks the physical connection, and let's get physically distant, but let's break the fear chain as well, and we'll all do much better together.
I like that. I like that hashtag. Okay, let's see. All right, we kind of touched on acetaminophen versus ibuprofen, but this is specifically a question for Brugada patients. Have you seen any data regarding the fever patterns in COVID patients, and how high are fevers going? And is this easy to manage with Tylenol?
Yeah, great question. So I would say the fever is all over the place with COVID. Most barely know they have it. So I'll give you an example at Mayo Clinic. When I walk into work, before I walk into the work, we all are to check our temperature. And I think if our temperature is greater than 100.5, we are to turn around and not come into work or not have left for work. So it's a low grade temperature for some. Obviously, if it's an obvious one, it's more, but whatever the temperature is, 100 and 100.5, 101, so forth, 40 degrees Celsius, if you like Celsius, that's 104. You should lower it, and you should lower it with acetaminophen until we get direction and guidance that ibuprofen is safe after all. The early concern is that ibuprofen may not be the best way of lowering fever. And so for our patients, I'm advising use of acetaminophen. And it works. And if you do have that fever and you do have Brugada syndrome, where you've learned and heard that we've told you that fever is potentially Brugada dangerous, don't freak out. It just means you have Brugada, you have fever, lower the fever, take your Tylenol. Remember, as you take your acetaminophen, take what the bottle says. So we know that if you take too much acetaminophen in 24 hours, that's 3,000 milligrams or 3 grams, you can provide an insult, and a significant one, to your liver. So take the right amount of acetaminophen, and for sure, don't be taking more than what the bottle says for your Tylenol.
Absolutely. Okay. Do you have any quick tips for Timothy syndromes and COVID-19?
Yeah, so my Timothy syndrome family's out there, and for those who don't know, Timothy syndrome is incredibly rare. So if long QT syndrome is 1 in 2,000 people, CPVT and Brugada syndrome is perhaps 1 in 5, 1 in 10,000. Timothy syndrome is, about 1 in 200,000 people or less. So
Wow.
really rare, and you can imagine that means there's not only zero data, there won't be any data. I mean, from a practical standpoint for this same time horizon. So I think the same thing that everybody should be doing, everybody, Timothy syndrome people, individuals should do it. Much of Timothy syndrome is due to mutations in the L-type calcium channel. And I think the physical distancing for you with Timothy is the same as for me. The hand washing for you is the same as for me. If you didn't get the influenza vaccine for whatever reason last year, get it next year. And hopefully a year from now, we'll have the coronavirus vaccine. If it's available, we should get it and listen to what is known at that time, of course, in case they say certain people should get it and whatnot. But Timothy syndrome or not, let's all be doing the exact same thing. But you should not be doing it anything more or less thinking that you are more insulated because of your Timothy or that you're more fragile because of your Timothy. Let's just do all of the things together.
Yes, absolutely. Get your flu shots. Big
Yeah.
takeaway. I just wanted to say we have almost 300 viewers right now, which is so exciting.
Well, we have 300 viewers. I have to take a coronavirus long QT pause. Can we do that a second, Michaela?
I think we should be able to.
Let me show you something, everybody.
Oh, yeah.
You got to see this. This is an amazing day for the Ackerman family. And let me find it. Okay, first, if you haven't seen, there's my granddaughter. That is Jaden Ruby Lorraine. She's almost 8 weeks old. I was supposed to be there last weekend in California, but you know what disrupted that. And then just today, for every fourth-year medical student in the United States, one of the most significant days in the life of an American physician or a U.S. trained physician is something called Match Day, where just an hour or two ago, all fourth-year medical students at every medical school everywhere found out where they're going for their next 3 to 8 years of their residency training. And what an amazing time to be a physician. And we have some incredible next generation physicians. But today was Match Day. That's usually a day of all families fly to that medical school with moms and dads and siblings and spouses. But like every other social gathering that we've needed to do a coronavirus abandonment, so was Match Day. And so Match Day is extra special for me because, can you see? That's my oldest son, the father of my granddaughter, who is coming home from California. So he will be doing his psychiatry residency training at University of Wisconsin-Madison. And so while we were physically disconnected, we were live together on social media, vis-a-vis Zoom, to see him get his match and join in real time with that. So to all of our future physicians, where you now know where you're going to be going for your next 3 to 8 years, congratulations. I'm so proud of all of them. I'm incredibly proud of our Mayo Clinic Alex School of Medicine medical students and of my son. So that's a little coronavirus long QT break. But thanks for all of those watching to let me to indulge me in a little moment of daddy pride. So well done, Jager. I doubt he's watching. I think he's celebrating alone in quarantine with his wife and daughter. So
that's so exciting.
That's a little break for us, Michaela. So now let's, I guess, get back to business for another 5 or 10 minutes if people want to.
Yeah, perfect. We'll get a few more in, and then if we continue this next week, we will take all the questions that we didn't get to today so we can get those answered for everyone.
That'll be great.
Okay. So the next question is from a patient in Germany. They are asking, is it possible to provide a special treatment for doctors and hospitals who will take care of those long QT patients who may need to be hospitalized due to coronavirus and need to take long QT prolonging medication, to clarify what they should consider in the treatment of long QT patients with medications like this?
Yeah, great question for my friends in Germany and for all of my friends and loved ones in Italy and throughout Europe. I'm thinking of all of you, praying for you, and we're here with you. And we're going to get through this. That specific question, things are moving fast, Michaela. So what I had just told you here in the States of, we have a drug, they have the drug there in Germany. Efficacy is being determined. Early signals with hydroxychloroquine and chloroquine are encouraging. There's a good reason to say, let's be hopeful. There's other investigational drugs that are not as far along the process. Chloroquine has been around, I think, since 1934, where we can use it right now off-label. The issue is, how do we counter the QT reactivity that could occur? So while it could effectively treat the coronavirus, we have to figure that out, make sure that's true. We don't want it to cause an unwanted drug-induced QT reaction that leads to a fatal arrhythmia. Some would say, well, who cares about that fatal arrhythmia? If a few people die off suddenly from that and yet it works, that's better. I want to save lives for everyone. So I want it to work if the drug works, and I want us to be aware who might be more QT fragile in exposure to the drug, and then have an intentional strategy. I think, so for example, if I know this drug works, and we'll learn that in near future, and I had long QT syndrome, and I was asymptomatic with my long QT syndrome, and my QTC was unimpressive, barely could detect it if I didn't have the genetic test to tell me that I own the variant, I would absolutely take the drug if it were me and I knew it worked. And I would monitor for my QT reactivity, just like we are starting to set up recommendations for anybody and what should be any person's QT monitoring. We will get this paper out soon to guide our physicians. The issue right now is, in order to know your QTC before you get the drug and on the drug, you have to get a 12-lead electrocardiogram. That means, how are you going to get that 12-lead electrocardiogram? You need to have somebody called an ECG technician, technologist, go in the room of a COVID positive patient and get that. The day before we start the drug, the day after the drug, if they're reacting, maybe more. And I think that is not an acceptable coronavirus exposure risk to our ECG technicians and technologists who are going to be using their PPE, personal protective equipment, and so forth. So we and others are rapidly working on a smartphone-enabled QTC meter.
Wow.
And this is where I'll give full disclosure. Mayo Clinic has been involved with this for over 3 years with a company called AliveCore. And some of you may have seen it. They're this gadget thing, their so-called cardiomobile device. And we've been working on that device. The cardiomobile from AliveCore has a current, and has had for a while now, FDA approved indication for atrial fibrillation detection. We've been trying to build into that device a QTC meter so that you could know, and physicians could know, what's my QTC by my fingers on the electrodes. We just received word from the FDA that we've been given emergency approval to utilize the AliveCore device for QTC monitoring. So we are building into the QTC, the AliveCore brain, the QTC meter. So we're going literally as fast as we can go. Mayo Clinic's been connected with AliveCor, so obviously there is relationship, so-called relationship with industry, full disclosure. I and others here at Mayo Clinic are involved with that, but we have been moving as fast as we could even before coronavirus and even before we thought that there might be a drug that might work. And this has just given us even more reason to move even faster, because I have felt for a long time that we should be thinking of the QTC as the next vital sign. And there's information. So if I knew what my patient's QTC was daily, we could have counter strategies. More to follow. I'll update you next week on what is the state of things, but literally just during this 36 minutes, I received notification from FDA about the emergency clearance for us to start providing the AliveCor Mayo Clinic cardiac QTC meter.
That's amazing.
And so that is available. I can order mine. It doesn't have the QTC reading feature on it right now. We're working to that, and in the meantime, until it shows you, my QTC is 450, 480, 520, whatever. We are working as we speak to have 24/7 real-time QT measurement for patients off of this device. So everything is moving, as the world knows now, fast, as it's all hands on deck to defeat this virus. And we're going to try to do our part such that if there is therapeutic efficacy with this QT prolonging medication or any of the investigational drugs that also have a QT prolonging signal, we can also mitigate the risk for anybody who has a detectable level of QT vulnerability, whether that's somebody who has genetic long QT or not, so that we can make sure to try to minimize any tragic collateral damage of treatment-induced, drug-induced sudden cardiac arrest. So I hope people are sensing optimism here, that whether we're company 3M that's unleashing the power of getting the N95 mask out, or other companies that are making defibrillators and now they're making ventilators. This is an all-out war, and we're proud to be troops in this army going to battle against this virus, and we're going to win. And I hope all of us do our part to flatten the curve. And so stay physically distanced. I don't like social distancing anymore. I like physical distancing, but socially connected. So we're far away today, but the 300 of you plus who we've joined together, we're very connected. And we, Michaela, like you know, at the SADS Foundation, we're here for the families. So maybe on that note, I'll just say on behalf of us at SADS Foundation, Alice Laura, our CEO, Michaela, and the rest of the SADS Foundation staff, we're here for you. www.sads.org. If you like the more optimistic way to get to our website, www.stopsads.org. And we will be sure that if this is bringing value to you, that we will do this next week, same time, same bat channel. And oh, sorry, bat. That was you get it, bat. Origin of the coronavirus. So anyway, I loved Batman back in the day. So anyway, I wish you all well. Refuse to fear. Be ready. Be prepared. Stay physically distant. Wash your hands. And we're gonna do well with this. And stay tuned. I'll update you on the great questions from today and any new questions that you have come next week at this time.
Great.
Well,
thank you so much.
Blessings to you all. And Michaela, thank you to you and your team for arranging this.
Yeah, thank you. I think this was a great turnout. I really liked the interactive, and everyone was able to watch and ask their questions. So we'll keep everybody posted through social media and emails through the next week just in case the time or days change. But I think this has worked great.
Great.
So
Bye, everybody. Take care.
Right.
Thanks, Michaela.
Thank you.